In this lecture, we will be continuing discussion of Chapter 7. This PowerPoint will focus on hospital outpatient prospective payment systems. The hospital outpatient prospective payment system covers hospital outpatient services, including clinic visits, ER visits, ambulatory surgeries. The effective period runs from January 1 to December 31st and is updated annually. The Omnibus Reconciliation Act of 1986 mandated that Medicare move to a prospective payment system for hospital outpatient services. Congress instructed the Secretary of the Health and Human Services to include facility costs for services provided in ambulatory surgery units, ERs, and hospital clinics within this system. Professional services such as physician fees were not intended to be included in this hospital outpatient prospective payment system. The legislation prescribed that the system was to be based on HCPCS Level 1 and 2 because that's the prevailing coding system used in the outpatient setting. That act gave Medicare 5 years to develop the system with a projected implementation for 1991. This screen lists some of the reasons why implementation of a prospective system was sought after for the outpatient setting. DRGs were very successful in the inpatient setting. Costs for outpatient services were rapidly increasing. Hospitals shifted inpatient costs to the outpatient side after DRGs were implemented. To try and ensure consistency in procedure reimbursement and in beneficiary responsibility. Before the prospective payment system in the outpatient side, it was a cost-based payment. The beneficiaries were responsible for 20% of charges, and what beneficiaries were paying was inconsistent from hospital to hospital. For example, Hospital A might charge $3,000 for a colonoscopy, where Hospital B may charge $3,500 for that same procedure. And then you can see how that impacts what the Medicare beneficiary is paying to each hospital. A grant was awarded to 3M in 1988 to develop a grouping system for the outpatient prospective payment system. In 1990, 3M did propose version 1.0 ambulatory patient groups, or APGs. The APG system, that's a visit-based classification system that describes the amount and the type of resources that are consumed during a particular visit. A visit is an encounter between a patient and a healthcare provider. In 1995, then, 3M released an updated version, which was APG version 2.0. So APGs are still used in many states for Medicaid reimbursement only. In 1997, the Balanced Budget Act set new dates for Medicare to move to a prospective payment system. That deadline for hospitals was January 1, 1999, and was 1 year later for inpatient prospective payment system exempt cancer centers. In September of '98, CMS released the proposed rule for the new outpatient prospective payment system. The grouping system in the proposed rule was called Ambulatory Payment Classifications, or APCs. APCs were developed by modifying that initial APG system that was created by 3M using past claims data and clinical analysis. Before implementation of the APC system proposed in '98, the Balanced Budget Refinement Act of 1999 did require several modifications to the system. It mandated annual reviews of groups, weights, and wage index adjustments, similar to the review that is done for the inpatient side. Medicare was instructed to develop a professional advisory panel to help assist with the maintenance of the system. It was determined that beneficiary coinsurance for any given procedure could not exceed the inpatient deductible for that year. The Medicare Prescription Drug Improvement and Modernization Act of 2003 did further modify the outpatient prospective payment system. MMA now allows payments for an initial preventive physical exam for beneficiaries whose coverage began after January 1 of 2005. MMA did change the screening and diagnostic mammography payment from the outpatient prospective payment system to a fee schedule payment. CMS uses a variety of models to reimburse facilities for their hospital outpatient services. The system uses 3 reimbursement methods: fee schedules, prospective payment, and also cost-based. The primary standard that distinguishes a prospective payment system from a fee schedule system is that in the prospective payment system, the costs for certain items and secondary services that are associated with the primary procedure are packaged into a payment for that primary procedure. A fee schedule system that establishes a separate payment amount for each item or service, and there is no packaging that occurs. The outpatient prospective payment system does require facilities to use Level 1 and Level 2 HCPCS codes to report services or procedures performed and also items or supplies that are provided to beneficiaries. Each code in HCPCS has been assigned a payment status indicator. What this indicator does is establish how that service, procedure, or item is paid. That is it a fee schedule, APC, reasonable cost, or is it unpaid? And this is a small sample of a few of the payment status indicators. Every year, the Secretary of the Health and Human Services does review claims data and determines which procedures are inpatient-only procedures and does create an inpatient-only list, which equals payment status indicator of C. To move off of the inpatient-only list, a procedure must be performed in outpatient settings at least 60% of the time. To be reimbursed, procedures that are indicated as C or inpatient only must be provided to Medicare beneficiaries in an inpatient setting and then therefore paid under the inpatient prospective payment system. CMS or Medicare does maintain the outpatient prospective payment system. As was mandated, Medicare must perform an annual review of APC groupings and of relative weights. The wage index amounts adjusted for the current inpatient prospective system must also be incorporated into the outpatient prospective payment system each year. In addition, the payment amounts are really updated every year based on an adjustment to the conversion factor. There's also an APC advisory panel that assists with the maintenance of the outpatient prospective payment system. That panel is composed of 15 experts from various healthcare settings. The panel is technical in nature and really provides an analysis and recommendations back to CMS. And then CMS will consider and address all of those recommendations, but they do not have to accept those recommendations. In addition, the Medicare Payment Advisory Commission, or MedPAC, does provide Congress and CMS with recommendations to try and improve that outpatient prospective payment system. Again, Medicare considers and responds to all MedPAC recommendations, but does not have to accept or implement them. Revisions to the prospective payment system, the outpatient side, are released in the Federal Register, the proposed rule in July, and the final rule in October. Each APC group composes procedures and services that are really clinically comparable with respect to the level of resources that they use. All procedures or services assigned to an APC group must meet the 2 times rule, which establishes that the median cost of the most expensive item or service within a group cannot be more than 2 times greater than the median cost of the least expensive item within that same group. Medicare can propose exceptions, of course, to that 2-time rule. Packaging and bundling concepts are used in the outpatient prospective payment system really as a way to combine payment for multiple services. In 2008, the outpatient prospective payment system final rule, Medicare defines packages and they define bundling. Packaging occurs when reimbursement for minor ancillary services associated with a more significant procedure are combined into a single payment. Bundling, on the other hand, occurs when payment for multiple significant procedures or multiple units of that same procedure related to an outpatient encounter or an episode of care is combined into a single payment. By using these packaging and bundling concepts, CMS provides incentives for facilities to try and improve efficiency by avoiding unnecessary services, supplies, and pharmaceuticals, and by substituting less expensive but equally effective options. For calendar year 2008, packaging of ancillary and supportive services was expanded. Medicare did move several procedures into 7 categories to packaged or conditionally packaged status. Those are guidance services, image processing services, intraoperative services, imaging supervision and interpretation, diagnostic radiopharmaceuticals, contrast media, and also observation services. Other services are not packaged into the APC payment for the service or procedure for which they are associated. Although some services are packaged, many others are not. Ancillary services such as X-rays, MRIs, minor procedures such as injections are not packaged but are paid separately via APC groups. This allows for an unlimited number of APCs to be assigned per encounter. In the outpatient setting, treatment paths really vary from patient to patient, making it much more difficult to determine the resources that will be consumed for a particular clinical issue. So consequently, average costs for a typical encounter really could not be accurately forecasted. Therefore, a partially packed system provides for more flexible adequate reimbursement, and it allows a treatment flexibility that really is needed to appropriately care for patients in an outpatient setting. In 2008, CMS did add the concept of what we call composite APCs to the prospective payment system in an effort to move toward an episode of payment-based payment system. The creation of composite APCs allows for multiple services that are typically performed together to be reimbursed as one APC rather than multiple APCs. CMS did introduce 5 composite APCs in 2008 that are listed on this slide. With the inception of the outpatient prospective payment system, the APC system bundled cost for observation services into an APC payment for the procedure or the visit in which the observation was associated. However, in 2002, a revision added APC 0339 in order to pay separately for certain observation services that were associated with clinic visits, ER visits, or critical care services. 3 clinical conditions qualified as an observation service for APC 0339. These were chest pain, congestive heart failure, and asthma. 2 composite APCs are provided for observation services. Level 1, Extended Assessment and Management composite. Level 2 is Extended Assessment and Management. Observation services must be provided for at least 8 hours and provided on the same date of service as a high-level clinic visit, so that's a 99205 or 99215, or a direct admit to a facility in order to activate what we call a Level 1 composite APC, which falls into 8002. In addition, a surgical procedure, which is a payment status indicator of T, cannot be performed on the same day or day before the observation service. Level 2 composite APC, which is 8003, that criteria is really similar to Level 1. Observation services must be provided for at least 8 hours and provided again on the same date as a high-level ER visit or a critical care service. And in addition, a surgical procedure that has a payment status indicator of T cannot be performed on the same day or day before. All observation services that do not meet the composite APC criteria are then bundled and do not receive separate payments. Partial hospitalization, that's an intense outpatient program of psychiatric services that's provided to patients who have an acute mental illness as an alternative to inpatient psychiatric care. Partial hospitalization may be provided by hospital outpatient departments and also by Medicare certified community mental health centers. Patients who do receive psychiatric services and have a diagnosis of an acute mental health disorder are grouped into APC 0034, Mental Health Services Composite. The unit of service for a partial hospitalization is 1 day. Therefore, APC payment for APC 0034 is based on a per dime amount. For calendar year 2012, the APC payment rate for that is $191.13, of which $38.23 is the beneficiary copayment amount. This slide also lists the calendar year 2013 payment and coinsurance amount. In the APC system, there are 10 types of APCs. The type for any APC can be identified by the payment status indicator that's assigned to the APC and the procedures and/or services in that group. All procedures or services in an APC have the same payment status indicator type. The 10 types are listed on your screen. Each HCPCS code is assigned to one and only one APC. The APC assignment for a procedure or a service does not change based on a patient's medical condition or the severity of their illness. There may be an unlimited number of APCs per encounter for a single patient, as we talked about earlier. The number of APC assignments is based on the number of reimbursable procedures that were provided for that patient. The one exception to APC not changing based on severity is if it's a partial hospitalization. Each APC contains the same components that really drive the APC assignment. This is title, payment status indicator, relative weight, as we've already discussed in some earlier chapters, a national unadjusted payment amount, which is the total amount the facility will receive, the national unadjusted co-payment amount, that's the portion of payment that's the beneficiary's responsibility, and then the code range drives APC assignment, and remember those are based on HCPCS codes. This is a sample of APC 0609. You can see the HCPCS code that did drive this APC. The payment status indicator is V. Both the Medicare facility component and the beneficiary co-payment components are adjusted for differences in wage index. This is the only adjustment made to the APC payment rate to account for differences among hospitals. 60% of the facility amount is wage index adjusted. The wage index amount for the facility location is based on core-based statistical area and is determined in the inpatient prospective payment system update for each fiscal year. New technology APCs were created to allow new procedures and services to enter the outpatient prospective payment system quickly, even though their complete cost and payment information is not always known. New technology APCs, they really house modern procedures and services until enough data is collected to properly place the new procedure into an existing APC or to create a new APC altogether. A new procedure or service can remain in a technology APC for an indefinite amount of time. The APC system does contain 82 new technology APCs. 41 of those have a payment status indicator of S and are not subject to the multiple procedure discount. The remaining 41 groups have an indicator of T and are subject to multiple procedure discounts. This is a sampling of some of the new technology APCs. The APC system does use provisions to provide additional payments for high-cost items or unusual admissions. When multiple surgical procedures with a payment status indicator of T are done at the same operative session, they are discounted. The highest weighted procedure is fully reimbursed, and all other procedures with that payment status indicator of T are only reimbursed at 50%. This reduction is made to account for resource savings that hospitals experience by performing those procedures together. The high-cost outlier provision is intended to provide financial assistance for unusually high-cost services. The equations for case qualification and additional payment levels are adjusted each year. Medicare limits the percent of total payments that can be attributed to an outlier payment to 2%. The Affordable Care Act of 2010 does provide for an adjustment to dedicated cancer hospitals to address the higher costs that are incurred by this type of facility. For 2012, there are 11 inpatient prospective payment system exempt designated cancer hospitals. The particular adjustment factor used is facility specific. Medicare will compare each facility's cost to payment ratio, or PCR, with the target PCR for any given year. Additional payments will be provided to the facility, so the facility's PCR will be equal to what the target is. The target PCR is the weighted average PCR for all other hospitals that furnish services under outpatient prospective payment system, and these are non-cancer hospitals. For 2012, the PCR is 0.91. Pass-throughs are exceptions to the Medicare prospective payment system. These exist for high-cost services. Pass-throughs are not included in the packaging component and are passed through to other payment mechanisms in order to attempt to adjust for the high cost. Pass-through payments were established to provide hospitals with additional payments for high-cost drugs or devices. These are broken into two APC groups. Status H is devices, status D is drugs. The BVRA did provide a mechanism for hospitals to decrease the financial burden for the implementation of this outpatient prospective payment system. This phase-in period provided the transitional corridor payments. They were provided beginning in the year 2000 and were discontinued December 31 of 2003. Hold harmless payments are permanent for inpatient prospective payment system exempt cancer centers and for children's hospitals. Eligible facilities, do receive a quarterly hold harmless payment that provides additional reimbursement when the payment received under the outpatient prospective payment system is less than the payment the facility would have received for the same service under the prior reasonable cost-based system. The interim payment is based on the most recent data from the Medicare cost report. Outpatient prospective payment system payment is determined using a 7-step methodology. Step 1 is APC assignment. Hospitals will submit a claim to Medicare for payment. Claims are sent electronically. Each claim will contain visit information, patient, facility information, detailed charges by procedure code, and diagnosis codes. Step 2 is when APC payment rate is established. The payment rate is calculated by multiplying the relative weight for that APC by the conversion factor for the current year. Step 3, the wage index is adjusted to national unadjusted facility component. The facility component of the APC payment rate is wage index adjusted. The formula is listed here. In step 4, the fee schedule amounts are applied. HCPCS codes with a payment indicator of A are paid based on a fee schedule. The fee schedule amounts for these procedures or services are applied by the Pricer software. Step 5, we have reasonable cost amounts that are applied. HCPCS codes with an indicator of F or L are reimbursed at a reasonable cost level. Step 6, Medicare payments are totaled. All the payments, whether it's APC, fee schedule, reasonable cost, are all totaled and summed for the claim. In step 7, any outlier add-on payments are applied. This amount is then added to the total Medicare payments. The APC system is very complex to manage, and cost analysis and containment still remain as the major driving forces behind the APC system.